The Centers for Disease Control and Prevention was designed to succeed quietly. Its victories rarely made the evening news because they were measured in absences. The outbreaks that never ignited, the ICUs that did not overflow, the funerals that did not occur. That is what a functioning public health system looks like. Science translated into systems, uncertainty turned into actionable guidance, and vigilance that most people never have to think about. In just a matter of months, that quiet machinery has been stripped of leadership, hollowed of expertise, and scattered across agencies and exits. The result is not simply bureaucratic turmoil. It is the active dismantling of the infrastructure that kept Americans safe. This is not a debate about personalities. It is about capacity. The CDC's strength has always been as an integrator, knitting together state labs, hospitals, federal regulators, international partners, and industry into a coherent whole. When that center holds, information flows to where it is needed and action follows. When the center is weakened, signals fragment, responses slow, and failure compounds. The loss of senior leadership, mass layoffs, and program shutdowns have triggered precisely that kind of fragmentation. Systems that once reinforced one another now work at cross purposes or not at all. Consider food safety. For decades, PulseNet, the CDC's genomics-based outbreak detection network, linked state and federal labs into a single lens on pathogens like Salmonella, Listeria, and E. coli. That lens is how we connected seemingly isolated illnesses, traced them to a common source, and moved the FDA and industry toward targeted recalls before a trickle of cases became a surge. Without sustained sequencing, curation of reference databases and national coordination, small clusters remain invisible longer. Days matter. In foodborne outbreaks, a delay of days means hundreds of additional exposures. A delay of weeks is catastrophe. If we degrade PulseNet, we will detect less, later, and at greater human cost. Hospitals tell a similar story. 2 decades ago, central line-associated bloodstream infections were killing thousands of patients a year. The CDC's National Healthcare Safety Network, coupled with evidence-based guidelines, made infection control measurable, comparable, and improvable. Hospitals standardized insertion checklists, enforced barrier precautions, and measured themselves against national benchmarks that were continually refined. It worked. Bloodstream infections plummeted, and tens of thousands of lives were saved. But surveillance is not a one-time fix. It is a continuous process that keeps practice aligned with evolving evidence. If the NHSN withers, the feedback loop breaks. Checklists drift out of date, benchmarking collapses, and preventable infections reclaim ground physicians and nurses fought hard to win. Seasonal influenza really underscores the same principle at a national scale. Each year's vaccine campaign hinges on surveillance that anticipates circulating strains, recommendations that mobilize the health system, and logistics that deliver doses where people actually live. When that chain is intact, vaccination prevents millions of illnesses and many thousands of hospitalizations and deaths. But when it's not, mismatches mount, uptake falls, and the virus finds new footholds. Influenza thrives on small failures, multiplied across millions of interactions. It punishes delay and disorganization. If you erode the CDC's role in strain monitoring and public guidance, you end up inviting predictable winter surges that strain emergency departments and, unfortunately, cost lives. The overdose crisis is a different pathogen with the same lesson. The CDC's near real-time mortality and morbidity data allowed states to target naloxone, expand medication-assisted treatment, and track the spread of new synthetic analogues. Those data did not end the crisis, but they replaced guesswork with intelligence and saved lives by moving resources with the epidemic's contours. When surveillance lags, fentanyl analogues outpace response, hotspots expand before they are recognized, and interventions arrive after the peak rather than before it. In public health, timing is the difference between suppression and cleanup. Right now, we are choosing the latter. The pandemic made this brutally clear. Through the Advisory Committee on Immunization Practices and the CDC's coordination with states, pharmacies, and health systems, the country executed the largest vaccination campaign in its history. By the agency's own modelling, millions of deaths and tens of millions of hospitalizations were averted. That success was not inevitable. It required a trusted national centre to translate evolving evidence into coherent recommendations and a distribution architecture that could scale. Weakening that centre now ensures that the next emergency, whether it's influenza's deadlier cousin, a novel coronavirus, or something we have not yet named, will unfold with less coordination, more noise, and sadly, more loss. Perhaps the strongest case for the CDC's value is actually the quietest routine childhood immunization. For 30 birth cohorts, CDC guidance, the Vaccines for Children program, and state and local partnerships have built the most effective shield modern medicine has ever created. The results are, honestly, staggering. Hundreds of millions of illnesses averted, tens of millions of hospitalizations prevented, and more than 1 million lives saved. This is really the definition of a public good benefits that compound over time because institutions sustain them. If we let coverage slip, let safety monitoring stall, or let recommendations become politicized, that shield thins. Measles resurges. Pertussis spreads. Polio, detected again in wastewater, tests whether we still remember why we built this system in the first place. The global dimension is not, a luxury. The CDC's technical depth and field presence underwrote polio eradication campaigns, measles control, and rapid responses to outbreaks in places where surveillance is fragile. That work kept pathogens from becoming pandemics. It also sustained US credibility as a reliable partner. Withdraw that capacity, and partners struggle, outbreaks smolder, and the world becomes noisier and riskier. In an era when a variant can circumnavigate the globe before a press conference is even scheduled, our borders are only as strong as the weakest surveillance node abroad. These are not isolated anecdotes. They describe a system of interdependent functions that either converge on prevention or, diverge into failure. When the CDC is resourced, independent, and led by science, information moves quickly to decision makers, practice adapts, and risk declines. But when leadership is purged, programs dismantled, and experts dismissed, the same network becomes a set of disconnected parts. Failures feed cynicism. Cynicism justifies more cuts, and we spiral from vigilance to vulnerability. The nation is trading a reinforcing loop of prevention for a feedback loop of decline. The path back is not mysterious. Restore the agency's independence so that recommendations arise from evidence rather than political pressure. Rebuild the workforce, beginning with the Epidemic Intelligence Service and the laboratories that anchor national surveillance. Stabilize and modernize PulseNet and the National Healthcare Safety Network so that detection and infection control remain continuous rather than episodic. Reaffirm the deliberative role of ACIP and the coverage policies that flow from it to keep immunization a shared baseline rather than a partisan signal. Recommit to global partnerships that extend our shield outward, because that is where tomorrow's threats will be visible first. These steps are pragmatic, not ideological. They are how a serious country treats risk. The stakes are straightforward. With a strong CDC, the country experiences fewer outbreaks, shorter hospital stays, and less grief. With a weakened CDC, delays lengthen, blind spots widen, and losses grow. The agency's finest work has always been invisible precisely because it prevented visible crises. We are about to be reminded, in ways that will be measured in lives and livelihoods, what invisibility was worth. We can choose denial and endure predictable harm, or we can restore the machinery that keeps danger at a distance. The quiet covenant of prevention is still available to us. It requires leaders who value evidence over impulse, lawmakers who fund systems before sirens wail, and a public willing to distinguish between the noise of politics and the signal of science. If we fail, it will not be because we did not know what to do. It will be because we dismantled the firewall and called it reform.